The serum albumin ascites gradient is a useful tool for determining the etiology of ascites. It's frequently tested on medical boards and exams, and it's often taught in a way that is way more complicated than it needs to be. To understand SAAG, you really only need to know two numbers and a few key concepts. This is SAAG made simple.
Now, the serum albumin ascites gradient, or SAAG as it's better known, has a very simple formula. It's just serum albumin minus ascites albumin. Now, to conceptualize this, here's how I think about it. Serum albumin is typically around 4. Ascites albumin is always going to be less than serum albumin, as there has to be a gradient for albumin to diffuse from the serum into the peritoneal space. Now, the SAAG is the difference in these values. As SAAG gets larger, the albumin in the ascites is lower, and vice versa. And this brings us to our first key concept. A high SAAG indicates low albumin in the ascites, and a low SAAG indicates high albumin in the ascites. The pathophysiology of ascites development is complex, and it involves a complicated interplay of hydrostatic pressure, oncotic pressure, sinusoidal fenestra, and it's beyond the scope of this video. But this analogy is a good model for conceptualizing the key factors at play to help us understand the pathophysiology rather than just memorize it. So, we can think about the blood flow through the portal vein as water moving through a fire hose. A stiff cirrhotic liver is much like clamping down on that fire hose. Upstream to this obstruction would cause an increase in pressure and dilation of the hose. Well, the same is true in cirrhotic physiology. Blood flow through the liver is decreased. This leads to an increase in portal venous pressure. Now, this increase in hydrostatic pressure causes water to diffuse out of the portal vein into the surrounding peritoneal space. Because there has been no disruption to the structural integrity of the system, larger molecules like albumin remain impermeable and therefore remain in the portal venous system and do not diffuse into the peritoneal space. Now, this leads to a low amount of albumin in the ascites, which means a high SAAG. And this brings us to our next key concept. A high SAAG indicates a problem of pressure, specifically high portal venous pressure, otherwise known as portal hypertension. Now that we understand this concept, let's expand on it. So after doing your paracentesis and obtaining your fluid studies, you'll need to determine your SAAG. Now, I mentioned before that you really only need to remember two numbers. Well, here's the first one. If SAAG is high, meaning greater than or equal to 1.1, it is a problem of pressure. Now, simply put, there are really only two things that can cause a problem of pressure, either the liver or the heart. So how do we differentiate between the two? Well, that's where the second number comes in. That's 2.5. Now, this is the total protein in the ascites fluid. Note that this is not like SAAG, which is the difference between two numbers. This is simply the value of the total protein in the ascites. Now, if you had to guess, which category do you think liver disease would go under? Many of the proteins in the blood are synthesized in the liver. So if the liver is dysfunctional for whatever reason, you might expect it to be producing less proteins, and that's exactly what we see. A total protein of less than 2.5 is indicative of liver disease. In addition to the liver making less proteins, cirrhotic ascites has low total protein due to hepatic sinusoids being less permeable to protein due to fibrous tissue deposition preventing the diffusion of proteins into the peritoneal space. We don't see this on the other side of the equation for heart pathology. Heart pathology such as heart failure causes an increase in portal venous pressure in a similar way to what we saw previously. Much like the kink in the hose that we saw with cirrhosis, heart failure causes back pressure of blood in the inferior vena cava and into the portal vein. Now, what if your SAAG is less than 1.1? Well, as I mentioned previously that with high portal venous pressure, there's no loss of structural integrity of the cells, which is why albumin remains in the portal vein. We have to ask ourselves what would cause such a cellular disruption to allow albumin to spill into the peritoneal space. Now, these are arguably some of the more sinister things. Pancreatitis that is so bad to the point where it is causing destruction of cells, leakage of pancreatic juices and cellular fluid into the peritoneal space can cause this. Peritoneal carcinomatosis or cancer, which is inherently destructive, can do this. Infections such as tuberculosis, which can be destructive, can cause these findings. Bile leaks, where you're spilling biliary contents, including proteins, into the peritoneal space can cause this picture. And the way that I think about it is like this. We have this cellular disruption which allows for protein and albumin to spill into the peritoneal cavity. Now, nephrotic syndrome is a little bit different, but it still fits on this side of the diagram. And I remember I used to ask myself why nephrotic syndrome would have a low SAAG, because a low SAAG indicates high albumin in the ascites, and nephrotic syndrome is a protein-losing nephropathy. So it seems paradoxical, but actually it makes a lot of sense if we think about it more. Now, this was our reference point when we started thinking about ascites, serum albumin being about 4, and ascites albumin being less than that. But we have to remember in nephrotic syndrome, we are losing protein. So serum albumin is going to be less than 4. And we've also mentioned that the ascites albumin always has to be less than serum albumin because there has to be a gradient of flow. So ascites albumin maybe looks something like this. Now, even though the albumin in the ascites is quite low, because serum albumin is so low, this leads us to still having a low SAAG. Nephrotic syndrome is the one exception here. It's a low albumin state in the ascites that still has a low SAAG. All right, now let's walk through a real-world example or something that you might see on an exam. You'll probably be given a general chemistry like this and some fluid studies, and you'll be asked to determine the etiology of ascites. Well, there's a whole bunch of data here, but we really only care about 3 numbers. So first, we'll need to calculate our SAAG. So if we look at our general chemistry, we see that our albumin is 3.6. Then we'll have to look at our body fluid studies and see what the albumin is in the ascites, which is 0.8. So we take the difference of these 2 numbers and we get a SAAG of 2.8. The next question we should be asking is the etiology of this liver or heart? And for that, we look at the total protein. So in this case, we see a total protein of 1.4, which is less than 2.5. And this suggests a liver etiology of ascites. And in fact, this patient had cirrhosis of the liver.
And that's it. Just 2 numbers and a few key concepts, and you can get most questions about the SAAG correct. I hope that was helpful, and I'm going to be making more videos like this, so let me know what topics you'd like me to cover. If you're a gastroenterologist, check out this video I made about how to interpret a Bravo study. All right, see you on the next one.